Morning, everybody. I hope I get through this without coughing. I have a pretty bad cough, which is residual of a never-ending cold. So, welcome to Saturday Night Live. Our musical guest today is Charles Calvo. We're going to talk about visual processing disorders. It's a very tough topic because it's something you don't see a lot of, you don't think a lot of, but of course is quite important for a select number of patients. So let's talk about a patient, a 75-year-old woman, has progressive visual difficulties over about 2 years. So she goes through a common route in academic centers, goes to glaucoma, and they say, well, you might have glaucoma. It's a little bit of cupping. Go to retina, and they see a tiny bit of AMD. She comes to neuro because, well, maybe it's neuro because she's getting worse. She describes things like when she goes to work, she comes out and she doesn't drive anymore because her vision bothers her, and she tries to open the car door and she can't find the handle. If she goes into a building, she can go through a regular door, but if there's one of those rotating doors, she can't figure out how to get in it. Over the last year or two, she's also had some memory loss. She had to give up her position as a business owner because she had trouble seeing. Past history of hypertension, hyperlipidemia, some TIAs, CHF, and she was a smoker. She was on a lot of medication. She's 2200 OU, but on isolated letters, she could see the 2060 line. She couldn't read any Ishihara plates, including the control plate. But when you ask her, she says, I have no trouble with numbers. And in fact, if you show her the tops of any of the drop containers, she could say red, blue, green, white, without any difficulty. Pupils were 2 to 3 plus reactive to light, no APD. She couldn't do a reliable visual field and normal intraocular pressure. And her extraocular motility seemed full at times, but if you asked her voluntarily to look in various directions, she often couldn't do it. And she had a normal appearing optic nerve and retina. When we showed her this and said, what is it? She'd say, it's an E. Well, is there anything else? No, it's an E. When we show her this, she says, there's a boy. And that's all she could say. She couldn't figure out that there were other things. So, what's going on here? Glaucoma, AMD, dry eye. So, obviously she's got a lot of difficulty with her vision, and her acuity's down, but she's got a lot more difficulty than you would expect based on 20/60 acuity, with her really not being able to function in life. And so she's got difficulty with processing of vision centrally. And actually, anybody want to do imaging? Like an MRI? So if you look at her MRI, which was called originally likely normal for age, you see that she's got a lot of atrophy, and the atrophy is in the back of the brain. And so what she has is posterior cortical atrophy, or the visual variant of Alzheimer's disease, which is a degenerative disease that starts posteriorly with the same pathology as Alzheimer's. Now, you could have other pathologies like frontotemporal dementia or any of the other neurodegenerative diseases that more anteriorly would affect language or memory, but they can start posteriorly and give you visual difficulties. Often it turns out with homonymous hemianopsia as well. So it wouldn't be surprising, because the atrophy here is more on the left, that a patient like this would have a right homonymous hemianopsia. But as I told you, she couldn't really cooperate for the field. So we're going to talk about processing of vision. Vision is a complex function. It has a lot of raw data that we have to process, and it's acted on at multiple levels, beginning in the eye and the retina, and going all the way to the areas beyond the visual cortex. There is serial processing, meaning that things are sequentially processed at times, and there's parallel processing, so they're processed in parallel. And so when we look at something visually, we're able to tell many end products, the color of it, the motion, depth, texture, patterns, objects. There are many different things about vision that we basically take for granted. We just look at something and recognize it. But there are a lot of features that feed into our understanding of what an object is. We have writing. We have to be able to look at writing. We have written language. We have faces to recognize. Stationary objects, moving objects, and all these things have to be processed and recognized, right? We have to take this processed visual information and correlate it with information from sound, touch, other senses. We have to correlate it with a reference library in our brains that we are able to recognize something or somebody based on what we've got stored in our reference library. So we have a few pathways. We know that there's different magnocellular, parvocellular pathways that begin in the retina itself, but then after we get to the visual cortex, we have this occipitotemporal or ventral pathway, which is mainly parvocellular, and is the what pathway. It tells us color, shape, pattern. What is it? Then we have the magnocellular pathway, which is the dorsal pathway, and that tells us more about where things are, localization in space, as well as movement, and that's occipitoparietal. Okay? So we have these different pathways that focus on different things. Now, basic visual pathway defects are pretty easy to figure out, mainly based on what kind of visual field pattern we have. If we're anywhere from the optic nerve through the occipital cortex, our visual field defects, whether there's decreased visual acuity, whether there's an afferent defect, is it homonymous, is it bitemporal, helps us localize where the lesion is. When we get into higher cortical function, it's not so easy because we don't have any really localizing visual field defects that say, hey, this is a temporal lesion, for instance. Sometimes it's easy. So a patient presents with a stroke or a tumor, they've got a hemiparesis, they've got an aphasia, but they've also got a visual problem. And so even though you may not characterize it perfectly well, you know what the cause is and what you have to deal with. But it often presents isolated without any other neurologic symptoms to an ophthalmologist with visual symptoms. And the patients are often told they've got a normal eye exam, and it's not till months or years later that someone figures out that it's a visual processing defect, and they really do have a brain disease. So diagnoses in these patients are often delayed. So to figure this out, if someone comes in with visual problems and you don't find anything in the eye itself, and you don't find a hemianopsia, but you're worried about a neurologic process, you've got to do a tailored history and ask for specific things. Do you have multiple or perseveration of images, such as palinopsia? Do you have multiple images? And if you have a brain disease, you can see multiple images. It's not always dry eye or cataract. But these patients have polyopia. They see many different things, not just the shadow double of a refractive error or astigmatism. Displacement of images. So they think something is here when it's actually here. So that's a visual allesthesia. And visual agnosia. So they can't recognize an object if they look at it, but then you put it in their hand and they feel it and they can tell you what it is. Difficulty with complex scenery. So you have a complex scene, you're looking at a picture, or you're out in public in an amusement park. There are many things going on, but there's a limited amount of attention, and so the patient can only see one little part of it. That's called simultagnosia. Difficulty recognizing faces, also known as prosopagnosia. Difficulty reading, dyslexia or alexia, particularly if it's not a simple print, if it's handwritten or script. Some patients have visual hallucinations, and very often are reluctant to report it for fear of being called crazy. Excuse me. And people have to be reassured that with a lot of neurologic issues, and in particular with loss of vision, such as the patients with macular degeneration that have release hallucinations, they often have to be coaxed into giving their history by explaining to them that it's expected if you have visual loss that you'll have visual hallucinations. And hallucinations can be simple, unformed. They could be complex or formed. You want to describe the location, the content, the duration. And again, it's most commonly secondary to visual loss. So when basic visual function is intact and people have symptoms, suspect a disorder of higher cortical visual function. So we're going to go through many of these types of disorders. We have disorders of recognition. We have disorders of visuo-spatial relationships. And we have disorders of awareness of patients' vision, awareness that they're seeing something or awareness that they're not seeing something. So disorders of recognition, most commonly called agnosias, include object agnosia, prosopagnosia, Akinetopsia, Alexia without Agraphia, and Cerebral Achromatopsia as some examples. So object agnosia. You give the patient these dice to look at, and they don't know what they are. If you put the dice in their hand, they say these are dice. And they're very familiar with it, they know how to deal with it, but they can't recognize it by vision, even though their basic visual field's intact. And this is usually a bilateral, ventral, or the occipitotemporal pathway dysfunction, sometimes seen with ischemia, with posterior cerebral artery infarction, sometimes encephalitis, sometimes tumors, etc. You could help bring this out, if it's subtle, by showing people unusual views and see if they recognize it. So you show a toaster from the top. You know, we're not used to looking at a toaster from this direction. It should be simple for someone who has normal vision, but for someone who can't process, they can't tell what that is. And some people with non-dominant parietal lobe lesions will have this difficulty. Similarly, you can give them an object decision task. You show them these objects, and you say, is this a real object, or is it not? So this is a distorted object. Here's a musical instrument on the body of an animal, right? Now, most people would recognize that that's not real. Here's the wrong head on this animal. Most people would recognize it's not real. But if you've got a visual agnosia, you'll say, oh yeah, that's a chicken, this is a bird, I don't know. So these are subtle tests to be able to tell if patients have an agnosia. Determines if the stored representations of familiar objects are preserved. If you don't have a good library, a good reference library stored, then you might think these two objects are real. You can ask people to choose the correct head for an animal. If you have no clue, you'll pick the wrong animal head, right? Facial recognition is very important, and the disorder of facial recognition is called prosopagnosia. So these patients often can assess the emotional state of a face. Maybe sometimes they can't. But even if they can identify it's a smiling face, whatever, they can't identify familiar people, or sometimes even more familiar people. Prosopagnosia, patients who can't recognize faces, usually also have difficulty with other visual memory tasks. And they often have a bilateral occipital lesion, but occasionally it's just a right inferior occipital, which also correlates with a left homonymous superior quadrantenopsia. Akinetopsia refers to the lack of ability to detect motion. So the patient can look at this and see the tank, see this guy on his bicycle, be able to describe it very clearly, but doesn't know that it's moving. Okay? That's akinetopsia. Involving the dorsal pathway, the areas are known as the V5-MT areas. Alexia is a difficulty with reading. And there are varying degrees, so that patients may not be able to read at all, or they may be able to read just single words, but not an entire sentence or paragraph. And if you can't read, sometimes you can't read the E chart, right? The letter chart, Snellen chart. You may have to look at the animals, right? So Alexia may make other tests erroneously abnormal, like visual acuity or color vision, if you can't read the numbers, for instance. So you have to know what kinds of defects you're dealing with to realize that sometimes people fall apart on other tests, even though they really can see. So Alexia without agraphia is the most famous type of Alexia that we see in ophthalmology, and it's the classic disconnection syndrome in neurology. What's a disconnection syndrome? It's a syndrome where one part of the brain, which is working okay, is disconnected from another part of the brain that's working okay, and because of that disconnection, they can't work together. So we have a left occipital lesion that gives us a right homonymous hemianopsia. But the lesion is large enough that it extends into the splenium of the corpus callosum. And what that does, so we have this lesion, left occipital, gives you a right homonymous hemianopsia. The right occipital region is normal, so you should be able to read with it. But the information has to go from the right occipital region to the angular gyrus, the language area, on the left side of the brain here. And it goes through the splenium of the corpus callosum. But guess what? This lesion extends to the splenium of the corpus callosum. These fibers can't work normally. They don't get through to there. So even though you can see the letters, you can't get it to the reading area. So we have a hemianopsia, which makes us not read on that side, and we have this disconnection that doesn't let us read on that side, so we have alexia. Well, is there a problem with the writing area? No, because the language area is intact, and writing is a frontal lobe function. And so the patient can write their name, and then 10 minutes later you show them their name, and they can't read it. Another parietal syndrome, which includes visual abnormalities as well as other things, is the Gerstmann syndrome, which is really four things. It's alexia with agraphia, so they can't read or write. They have right-left confusion. They can't distinguish right from left. They have a finger agnosia, so that you ask them to show me your left ring finger, and they'll put up the thumb. You say my pointer or index finger, they'll put up the middle finger. They may do that anyway, depending on how you're treating them. But, they can't recognize their fingers. They have a dyscalculia. They can't calculate. And the lesion for Gerstmann syndrome is in the angular gyrus of the dominant hemisphere, typically the left hemisphere. So that's Gerstmann syndrome. So a patient tells you they can't write, they can't read, but they've got these other features, most often with a middle cerebral artery stroke. Cerebral achromatopsia refers to inability to see colors. So colors look dull, some are colorless, some are shades of gray, so that the normally vivid, colorful environment that we have is not seen clearly. It may present with this isolated, or it could be patients who've had a stroke with loss of vision, and as the vision returns, they're able to have a normal visual field, but within that field, the colors are dull. It's usually in the anterior pathway, or the ventral pathway, the occipitotemporal pathway, usually in the lingual and fusiform gyri, which go into the temporal lobe from the occipital lobe, ventromedial occipital. Most often it's a bilateral process. It could be simultaneous, so a lesion that can come simultaneously, or it could be sequential. Someone's had a lesion on one side, and now the other side gets involved. You can have a unilateral lesion with a hemiachromatopsia. So you might have a hemianopsia on one side, but the other side you just can't see color. Or you have a side of space where you just don't see color, a hemiachromatopsia. And in that case, you might have a superior quadrantanopsia, but in the bottom field, you just don't see color. And it's associated with other deficits from lesions in the same area, like prosopagnosia or topographic agnosia, inability to localize objects. Sometimes associated with Alexia and other visual memory defects. So here's an example of what an achromatopsia might look like. You see the flowers and the leaves, and down here it just looks gray and white. You lose all the color. Most commonly it's vertebrobasilar ischemia with a bilateral posterior cerebral infarct. And other causes include mass lesions, encephalitis, migraine aura on occasion, patients with dementia. So a lot of different possible causes, and usually bilateral disease. So those are the agnosias, the difficulties with recognition. We're going to talk about disorders of visuo-spatial relationships, which include these listed here. And so we'll first talk about simultagnosia. Simultagnosia is the failure to integrate multiple elements of a scene to form a total picture. So, patient may see this picture, and you say, what's there? And they'll say, a pair of glasses. And if they see the glasses, they won't see the elephant. Or if they see the elephant, they won't see the glasses. Or if they see just the trunk of an elephant, they may not see the whole elephant. So there's a limited focus of attention that makes them not able to see multiple objects at once. So these people may do very poorly on the Ishihara color plates because you know that the Ishihara color plates are made of many little circles. And so there are many little objects, and so they can't put those all together. But if you show them colors, they may see well. So they may not have a color defect. They just, because of their simultagnosia, don't do well on the Ishihara plates. If you give them a complex scene like this cookie theft picture, which comes from the Boston Diagnostic Aphasia examination, they will do very poorly. A normal person will say, there's a kid on a stool, it's about to fall, he's trying to get cookies, his sister wants some, mom's washing dishes, it's overflowing, and she's not paying attention to the kids. Right? That's clear, it's obvious. Someone with some simultagnosia will say, there's a girl. They won't know how many people are in the picture, they won't be able to describe what's going on, or it'll take them a very long time. If you show them these letters, instead of saying that it's a T made up of E's, they'll either see the T without the E's, or see the E's and not the T, or see just one E. And of course, you should do this, you shouldn't do this after they're dilated and don't have their reading glasses and can't see the small letters, right? So it's 15 or 25 smaller letters, and it's difficult for patients with simultagnosia or any kind of posterior cortical atrophy syndrome. Optic ataxia is an interesting phenomenon where if you give them an object and they can see it, but they can't localize it. So you put up your finger, you ask them to touch it, and they miss it. And you might say, well, maybe it's cerebellar. Well, they're not having a tremor, and they don't eventually get it. And what you can do also is have them close their eyes and have them touch your finger and point their finger and actually get it there. With their eyes closed, they'll still do it. They'll get it perfectly because they don't have a cerebellar ataxia. Then they open their eyes and they miss it. It's just a visual ataxia called optic ataxia. And they complain that, I want to eat my cereal, I take my spoon and I put it in the coffee cup, or I put it somewhere else. And it can be confused with a depth perception problem, but it's a totally different issue. Now, Balint syndrome is a triad described by Balint. And that includes the two things we just talked about: simultagnosia, inability to look at many things in space; optic ataxia; and psychic paralysis of gaze. What these patients have is a difficulty of looking to the left or the right. If you did a vestibulo-ocular reflex, a Dahl's maneuver, they can overcome it. Shows you that it's not a problem with the cranial nerves. But if you just say look to the left, look to the right, they have a lot of difficulty. So this triad's been described in patients with brain injuries, in patients with bilateral strokes, with patients with mass lesions bilaterally. So it's called the Balint syndrome, and it includes these three issues. Of course, you could have any one of them by itself as well. Visual allesthesia refers to when you're looking at something and it's rotated, flipped, or inverted. So for some reason you're looking here at I believe the Colosseum, and it's rotated. And we see this with occipital-parietal lesions, but for some reason, patients who have the Wallenberg syndrome, stroke in the lateral medulla, also get this 90 or 180 degree tilt of the environment that comes and goes. Now, sometimes we have disorders of awareness of our vision or a visual loss. And some examples are Anton Syndrome, the Riddoch Phenomenon, Blindsight, and Hemispatial Neglect. So, Anton Syndrome are patients who are blind but don't admit or don't realize they're blind. So, most often it's cerebral blindness, so it's an occipital lesion. They can't see, but they will act as if they see. Typically, this is an inpatient. They've just had an anoxic event. They've just had an embolic event to both posterior cerebral arteries, and so they're blind. But you walk in the room and you say hello, and they say hello, and you see that they can't see because they're looking around, and you say, "Can you see me?" And they say yes, and you say, "What do I look like?" And they'll say, "Well, I'm 6'6" and thin, and and I'm wearing a nice bow tie and have a big beard," and they'll just hallucinate things. So they've got mental status changes because they're probably involving also their parietal lobes, and so they hallucinate and confabulate images. They make them up. Most commonly seen with bilateral occipital infarct plus some parietal involvement with mental status change, but occasionally you could have blindness from before, from the eyes themselves, end-stage glaucoma, AMD, etc., and now they have a new central nervous system lesion, and they'll deny that they're blind. The Riddoch phenomenon is the phenomenon of seeing a moving object when the stationary objects you don't see. So, with visual field defects, sometimes you just see this normally, right? So, patient can't see a stationary object, but then you move it and they see it. And some people think, well, they're faking it because they could see the movement. Well, it turns out that a moving object's much more of a stimulus than a stationary object. But there are people who can't see totally in one visual field, but if something's moving, they will. And that's called the Riddoch phenomenon. Blindsight is a patient who's got cerebral or cortical blindness, and they have no realization, but if something appears, they will react to it. So they'll flinch if something comes near their face, or they'll avoid an object, but they have no knowledge that they're seeing it. And this has been explained by having vision that they perceive that came through the superior colliculus. So it went from the optic tract directly to the brainstem, bypassing the lateral geniculate and the occipital cortex, or it went through the lateral geniculate but didn't go to the visual cortex, went directly to an extrastriate or the visual processing areas. So there's a perception of seeing something even though patient really doesn't see anything. Neglect refers to not seeing objects in an area where you think vision is normal. So you do a visual field and it's full, but the patient doesn't see things on the left side of space. And that's because even though it's there, they tend to ignore it. And you can demonstrate it with double simultaneous stimulation. So you put objects in their right and left field, and they'll see only the one in the right. They won't see the left. If you put it in the left field and just the left field, then they will see it. But when there's something else distracting them, they neglect it. It's most often a lesion in the right hemisphere, parietal or frontal eye fields, and cingulate gyrus. And it's the right hemisphere that mediates attention to both hemifields, so that it's really a right hemisphere problem when you get neglect. One of the ways to show neglect is a line bisection task. You draw them a line, and you say bisected in the center. So you give them a line, and you say, cut it in half with your pen. Here's a normal response, right in the center. If you've got a left-sided neglect, the patient will cut it towards the right of center, because they don't see the left side of the line, they see it ending maybe here. So they will move it to the right. So it's a simple test looking for hemi-neglect.
Still the same with binocular and monocular testing with neglect?
Yeah, right. So because it's a brain phenomenon, it doesn't matter if you check it with one eye, or the other eye, or both eyes. Another way to test for neglect, you show them this diagram and you say, do all the circles have a line? And they'll say yes. If they have normal attention, they'll say no. But if they neglect this side, they may not see that this one is missing the line. And what we see sometimes is just people are very slow on this, but they get it eventually. We'll talk about positive visual phenomena. These are either perseverations, so persistence of images that were there before, or hallucinations, the seeing of images that are not there. So the types of perseverations are cerebral diplopia or polyopia, Palinopsia, or illusory spread. So multiple images, we always say multiple images that are monocular are not neurologic, right? But there's a rare exception where you have multiple images that are neurologic, that are monocular, and they're monocular in both eyes, and they're not the ghost image of a monocular diplopia you're used to. They're clear images, and indeed, and it's not just two, it's often many. It may be associated with visual field defects, other things such as achromatopsia, object agnosias, difficulty with optic ataxia, and after images. And may occur when patients are recovering from cortical blindness. So first they're blind, both bilateral occipital infarct. As they're recovering some the next few days, they may see multiple images, even with monocular viewing, and they're all of equal clarity. So they see multiple images all over the place. And that's associated with palinopsia, which is the persistence of images that are gone, that are no longer present. So they both have multiple images, but also persistence of images. It could be immediate, right after the image is gone. It could be in the same location, or it could be elsewhere. And there have been some various mechanisms proposed. And so palinopsia, here's the hand is gone, but you still see the persistent image. Now, we normally often have after images. Like if you're running a mouse on the screen, you always see that, right? Or if you're batting, you can see it like that. But persistence of images after it's gone. So other causes are intoxications with hallucinogenics. And there are some people that we have, I've had two patients in the last 2 or 3 years who tried LSD once and had persistent images for years. And I don't know how you explain that, but it does happen. It happens with the fertility drug clomiphene, trazodone, the sleep aid, nifazodone. Of course, psychiatric disease can give you any of these things psychiatrically. But structural lesions, most often in the right parietal occipital region, but sometimes left-sided, sometimes bilateral, and sometimes the palinopsia is only seen in a hemianopic field. So the patient has a hemianopsia, and they've got persistence of images in that field. And sometimes it's widespread, this palinopsia. I think some of you have seen this before. The whole country did. So. More popular a few years ago. She was everywhere, right? Illusory visual spread is spread of an object beyond its normal boundaries. Okay, so you see this this person who's a little bit obese, but the appearance to the patient is much more than the boundary would suggest. Right? Illusions are false perception of visual information that is present. So in the external environment. So it's seeing something that's real, but not where you're seeing it. We see that sometimes with dry eyes, other anterior segment issues, or macular lesions. But with central disease, we often see hallucinations. It's a visual perception without external stimuli causing it. It could be simple, like spots, lights, dots, patterns, which is typically from the occipital lobes, or it could be formed hallucinations, seeing people, animals, flowers, buildings, which is usually more anterior in the temporal lobe. Ocular causes, any kind of distortion in the visual pathway, such as PVD, of course, gives you flashes, floaters, etc. RDs. Outer retinal disease, such as Azor, can give you very simple photopsias, hallucinations like that. With optic nerve disease, like optic neuritis, you can get phosphenes, flashes that appear, either with change in lighting condition or eye movement. We don't hear that commonly. We don't ask about it commonly, but if you ask your optic neuritis patients, you will occasionally hear about phosphenes. Photisms are visual phenomena that occur with other sensory stimuli. So sound can induce a little feeling of color, touch, taste, smell, sort of a cross between one sense and vision. Visual hallucinations can occur with normal mental status or with mental status changes. So that patients with dementia, metabolic encephalopathy, alcohol withdrawal, drug reactions, psychiatric disorders can all have visual hallucinations. But if they're mentally normal, it's a sign of either neurologic disease causing the hallucination or visual loss, which is release hallucinations. So the diseases with hallucinations are listed here. For instance, patients with Parkinson's commonly have hallucinations, particularly if they're on Sinemet. All these diseases can do that. Medications of various sorts can cause hallucinations. Illegal drugs, of course, can do that. Sometimes we see objects that are physiologic. So the branching of the vessels in our own eyes. In certain lighting conditions, people see it, right? And these are called Entoptic Phenomena. These visual effects whose source is within the eye itself. So if one sees these vessels, that's an Entoptic Phenomenon. And some people just see it all the time. Most people just see it when you're shining a bright light in your eye. For instance, you're getting examined with an indirect ophthalmoscope. And it's worse with sensory deprivation or sleep deprivation. The most common visual hallucination we see, Charles Bonnet syndrome, usually bilateral visual loss, usually grew less than 20/60. The visual hallucinations are felt to arise in the visual cortex, which is deprived of incoming visual sensation, and so it generates its own image. Perhaps a physiologic reaction to visual loss. The hallucinations can be simple, they can be complex, and they can be intermittent or continuous. And they're often present on certain backgrounds, like a light pastel wall, for instance, will tend to bring these out. Mental status in these patients is normal. The incidence is high in visual loss, but patients often will not tell you for fear of being thought to have psychiatric illness. We try to not treat these because the treatments are not good and the side effects are many. But you can try anticonvulsants or antipsychotics, which may help. And if the visual loss is understood, patients got known end-stage glaucoma, and as it develops, they get these. You don't have to do MRIs unless anything else is really normal. Seizures can give you visual hallucinations. If they come from the occipital cortex, they're simple. They're lights or colors, flashes. If they move more forward in the temporal area, you get more complex images. And so one of the classic findings in partial complex seizures of the temporal lobe is visual hallucinations. So EEG monitoring may be helpful in some of these patients. Migraine is the most common cause of visual hallucinations, and it consists of cerebral cortical hyperactivity electrically, followed by a wave of depressed neuronal function. So you have hyperexcitability, then you have inexcitability. These are binocular. They have these fortification spectra, which are the zigzag edges, sort of the end of a fort. You may have distortion of size. So micropsia, things may look too small, or macropsia, sort of the Alice in Wonderland, too large look. They can be formed or unformed. They often are described like heat waves on a radiator, cracked glass, kaleidoscope, fragmented vision. You know all the different descriptions of migraine. So here's one of the classic drawings of migraine. It's actually starting in a small area, and then it grows, and as it breaks up, after it's grown, it breaks up in pieces and goes away. And here's the clock going for like a half hour from beginning to end. So it may enlarge over time and move across the visual field, and often has this C shape to the entire area with these zigzag edges. Peduncular hallucinations is a very vivid hallucination where people have very detailed, very colorful, bright hallucinations that are continuous or episodic. They're associated with other sleep disorders, and it's called peduncular hallucinations because there's a lesion in the midbrain involving the cerebral peduncle. So there's a particular kind of hallucination that's extremely vivid, and these people have dreams that are very, very, very vivid. Occipital hallucinations, again, are very simple. Flashes of light, kaleidoscope, chicken wire appearance, simple shapes and forms. We touched on visual distortions. There's micropsia, where things look smaller. There's macropsia, where they look too big. And, of course, there's metamorphopsia, where the shape has changed. And most of these are macular disease. So micropsia occurs when the distance between photoreceptors is increased. So things look smaller, such as macular edema. So things may look smaller. So most often it's a unilateral phenomenon, and just in that eye, things look smaller. But if it's a bilateral process with a normal macula, it could be a cerebral micropsia. Psychiatric micropsia occurs, so some people with schizophrenia might say things look very small, and there's perhaps a Freudian explanation to distance someone from conflict. But cerebral micropsia, which is rare, is always binocular. Each eye has it. Occasionally it's in a hemifield, and the most common intermittent cause is migraine. Macropsia may occur in the late stage of scarring of macular edema, where the photoreceptors are closer to each other, but also occurs with seizures, occipital lesions, migraines, one of the causes, and parietal disease, where things look larger than they really are. So with parietal lobe disease, we can get micropsia, macropsia. We also have some phenomenon of telopsia. Things look all of a sudden like they're far away. Or pelopsia, they look like they're closer. The most common cause of metamorphopsia, a difference in shape, is of course macular disease. And you take out the Amsler grid and you just see it very clearly. But if it's similar and it's bilateral, it could be a cortical phenomenon. Color changes. We know that drugs, particularly digoxin, will make things look yellow sometimes. The ED drugs, maybe because of choroidal ischemia, it's not sure. People get blue vision sometimes. And color change with blue vision or other color vision, of course, in an appropriately aged person. You have to worry about choroidal ischemia, mainly from giant cell arteritis. The final thing that's a distortion in vision is called the Pulfrich Phenomenon, where you have a lack of ability to localize things in space, and if it's moving horizontally, it looks like it's moving in and out. So if you take a pendulum and swing it in these patients, it won't look like it's in one plane, it will look like it's going in and out. And that's because someone's had a unilateral demyelination in the optic nerve, and so both eyes are open, and the speed of conduction is greater in the normal eye than in the demyelinated eye, and so they get this false appearance because they're trying to combine the information from both eyes that there is an actual movement in the plane going near and far. So I think with that we'll end, and I thank you for your attention. I'm glad to take any questions.